A quick welcome to those who are joining. Thank you very much for coming to this, our first regional discussion group for Africa. It's fantastic to see so many people joining. Very warm welcome. I just thought, as the ICMLF Chief Executive, I would just give you a very quick overview of the International CML Foundation and our current activities. So really, our primary aim is to improve outcomes for CML patients wherever they are in the world. And we do this through two key areas. So really, raising the bar of CML management through CML education. So exactly like meetings like this, our regional discussion groups where we share expert opinions. We also have our live conversations bi-monthly where we have key experts from the different congresses where they share their opinions and highlights. We've had over 200 preceptorships where people, many of whom are on this call, have actually gone into centres of excellence to upskill and share knowledge back at home. And we also have our ICMLF Knowledge Centre where there are key topics. The second part of the organisation's aims at the moment is really harnessing the power of global research. So again, many of you are involved in our COVID-19 study, and from there we're now looking at genomics and treatment-free remission, where big data really has an impact on what we can learn about what's best for the individual outcome. So that's my very brief introduction. People are still joining us, but I think I'd now like to hand over to my colleague, Arlene, who will be your moderator for today. And the topic, as you know, realities of TFR in low and middle income countries and CML from the laboratory.
Thank you, Nicola. Hello and welcome to all of you. What a pleasure it is to greet you. Okay, so our first topic for discussion today is the realities of TFR in low and middle income countries. And it's a great pleasure to introduce our first expert for today, Dr. Matilda Ong'ondi from Nairobi in Kenya. Dr. Matilda is an eminent hematologist at the Kenyatta National Hospital and a good friend to the foundation. She was a tireless contributor to our CML COVID case collection and is on the Foundation's African Steering Group. We have found a nice routine with Matilda in sharing World CMLD events in Kenya through her leadership with the Kenyan Society of Hematology and Oncology. Matilda, thank you so much for joining us today. And our international expert for the TFR topic is Professor Tim Hughes from Adelaide in Australia. Tim is a giant in the CML field. He's known across the globe as a great physician and a great scientist. And along with Professor John Goldman, Professor Jorge Cortez, and Nicola, who you've just heard from, Tim was a founding member of the International CML Foundation, and he was the chair of the foundation until very recently. And actually having Tim and Matilda jointly leading this TFR session feels a bit like putting the band back together, as Matilda did a CML preceptorship with Tim in Adelaide in 2016. Welcome, Tim. It's a real privilege to have you here. So Matilda, would you please share your slides with us? And as you're doing so, I will share with the audience how we plan to run this session. So Matilda will spend a few minutes identifying key issues, problems, and challenges that she and other physicians across Africa face in pursuing TFR pathways. Matilda will then share a case. Tim will comment on the case, and then we'll open up to you, the audience, for a few questions and comments. Matilda will share a second case, Tim will comment on it, and then we can open up to the audience for a longer session of Q&A on any discussions relating to TFR that you like. Matilda, you are ready to go. Thank you.
All right. Thank you very much, and welcome to all the participants. I want to extend a very big thank you to the ICMLF Foundation for asking me to do and present a few cases and give our experience in Kenya. And I will start off by giving an overview of CML care, looking at the challenges that we have with TFR, and then go straight to cases. So in 2002, is when patients with CML started having access to the tyrosine kinase inhibitors. And this was through the GPAP initiative, which is the GLIVEC International Patient Assistance Program. And this was really cemented in 2005. And we have a volunteer clinic that runs every 2 weeks. For various reasons, the clinic was purely located at one central place so that we can have proper oversight in terms of the medications getting to the patients. And it's only in 2021 that we're able to have decentralization through some collaborations with the Ministry of Health. And we have other sites which have started, which have been very helpful to the patients in terms of reducing their travel, because patients prior had to travel to the capital city to get the treatment. And then also in 2007, we had a patient support group that was set up, which has really been instrumental in terms of encouraging and putting the patients together. Kenya has a population of 55 to 57 million, depending on which stats you look at. Life expectancy is 63 now, but you can see generally we have a young population, and this is also reflected by the data that is there in our current registry. We've had changes in the registry, so we've lost a bit of statistics, but the current registry has 1,347 active patients. If I was to look to the start of the program, I would say to date probably slightly over 2,000. But usually what happens is when a patient with CML is identified, then they have to do a BCR-ABL out of pocket, and that's where the challenge begins, because sometimes it takes time for patients to do the test. And there are many times that you have patients who may not be able to do the test. So sometimes when we see those numbers, they are not really representative of the true population. The mean age for this group is 44. So you can see compared to the West, we have a younger population, slightly male predominance, and most being in the chronic phase CML. Per the program guidelines, we start patients on imatinib, and that's why majority of the patients are on imatinib. And recently, we're able to have an initiative to have a TFR done on a few patients. And this is what I shall discuss, because you can only see that there were 3 patients who were put on that TFR program. So we know TFR is a discussion that is very key in terms of reducing TKI-related side effects, minimizing both the drug side effects and the economic impact, which is very important. And this has been well documented in various studies as illustrated there. And also, given that we have a young age, really reducing some of these toxicities when you have a growing population, the pediatrics and the adolescents. So this is an article which I would really recommend people to go through, because it was done by Pavlovsky, but looking at what TFR recommendations they have for Latin America, and maybe for the African setup, there are things we can learn from that, and then also a few things we can pick. And majority of the things mimic or are similar to what the other guidelines are. And I just want to emphasize on a few as I highlight the challenges. So you see, in terms of looking at TFR, first, are you able to do the test? Are you able to do a high quality test? And what is the turnaround time? When the program started, patients used to wait sometimes up to 1 month, 2 months, because the tests used to be sent outside. At least I'm happy to report currently with the institutions that run the tests effectively, the turnaround is 24 to 48 hours, but they're using the Cepheid Gene Expert testing, which has also undergone a few changes recently. And then the other challenge we have is majority of these patients pay out of pocket for these tests. So I have indicated there the cost of the BCR-ABLs, and you can see that our quantitative BCR-ABL is $81. So for majority of the patients who live under less than $1 a day, and you're asking for a test for $81 every 3 months, it's not, it becomes very challenging. The mutation testing is even more challenging because the mutation testing has to be sent out of country. So at the moment, what we encourage our patients is at least to do a BCR-ABL once a year, because we had a long period where you'd see the patient, you have the baseline PCR because they need it to access the program, but then you don't have any follow-up. And so many times you don't even know there's a problem when you have loss of hematological response or a loss of clinical response, which really becomes quite late. So that really paints a landscape of where we are. So some things are better than they were before. And I believe as we continue in this conversation, we should look at ways, maybe regional ways that we can still aspire for TFR, but taking into consideration the realities that we have on the ground with to do with testing. So at this point, if it's okay, Aline, can I proceed to the case? Thank you. All right. So I have two cases which may not really be representative of the whole patient population, but as we move along, you shall see why and understand even more clearly in the second case. So the first case is a 42-year-old male who was referred to the GPAP clinic in March 2021. He had symptoms 4 months prior of easy fatigability, went to get checked, was found to have a high white count, but did not follow up. So that's something that happens sometimes with patients. And then in February, so a few months later, presents for an annual check, again is found to have a high white count. He has no comorbidities, and on exam, he didn't have any hepatosplenomegaly. So at this point is when he actually followed up and proceeded to do more tests. So you can see his white count was 42. Most times when you see patients, their white counts are 200, 600, 400. This patient didn't have a splenomegaly. Most times when you see patients, they have a spleen that's in the pelvis. His bone marrow, he was in chronic phase CML. His BCR-ABL was at 43%. His UACs, LFTs were normal, and he was commenced on imatinib 400 milligrams. So this is a table that's just showing the hematological parameters. Clinically, he was otherwise well, didn't have any complaints during his follow-up. And I have put the time points at which he was able to do a BCR-ABL. So this is not your typical patient, because for this patient, he's been able to do BCR-ABLs every 6 months. So something stands out about this patient. So you can see at the 6-month mark, his BCR-ABL had gone down to 0.031. Hematologically, you can see there was a hematological response. If you recall earlier, I said that he didn't have a hepatosplenomegaly. So, and he was asymptomatic throughout the rest of his treatment. 12 months down the line, he had another BCR-ABL. He had a slight jump to 1.30, but you can see his counts were otherwise normal. And then to date, he had another BCR-ABL done, and this was now at the 16-month mark. And it was, showing he was in a deep molecular response. And I have put there a graph just to illustrate what, whether you're looking at WHO or ELN, what the milestones should be at specific months. And you can see for this patient, he's pretty much following the expectation or achieving his milestones, as it were. So for this particular case, we have a young man, 42 years. Remember, I said based on our registrar, mean age is 44. He's in chronic phase CML. Something stands out about this patient. He's able to do monitoring in terms of his BCR-ABL, which, as I've mentioned, is not typical. So is this a patient we should start the discussion of TFR early, given his consistent testing, so that it's something that he can look towards? So I'll allow Prof. Tim Hughes to carry on.
Okay, thanks, Matilda. So yes, an unusual patient because he has the ability to have regular testing. So it makes the conversation about treatment-free remission a lot easier and more realistic, I guess. So he had a actually really good response at 6 months, 0.03%. That's
Yes.
remarkably good. A little concerning, he went to 1.3% at 12 months. I don't know whether he got so excited about his good result he stopped taking his drug or something, but that's quite a rise. I would have been a bit worried about that, but strange enough, by 18 months, he's got an incredibly good response, 0.006. He's MR4 already and heading towards MR 4.5. So he is going to be one who will be very likely to be eligible for treatment-free remission. I think with imatinib 400 milligrams, we don't really consider it as an option before 5 years. So there's no hurry here to move him towards treatment-free remission. But I certainly would start a discussion. I talk about this with my patients at the start. I mean, that's because obviously we have the luxury to have that reality for all our patients. But for someone who can have regular PCR testing, I think it's worthwhile discussing at fairly early stage, because I think it changes the way that they regard their therapy. It's no longer just a chronic therapy that they have to take every day, put up with the side effects, and it's just like stretching out forever, because that's the situation where you get pretty patchy drug adherence. But if they know that there's a target, if at 5 years they're eligible, they have a 50-50 chance of being able to go off their drug and stay off their drug, it really does, I think, help to motivate them to take it every day, despite their day-to-day side effects. They tend to be much more vigilant at taking their drug. So I think it'd be very appropriate to have a conversation along the lines of, you're doing really well. I can see a time at around about 5 or 6 years where you might even be able to stop therapy. And it's a 50% chance that would be a long-term successful approach. But you take it every day now until then to give yourself that best chance, so that you don't sort of give them a message that they can sort of stop and start. It's only when they're eligible down the track. And now the challenge is, take this drug every day. You've done really well, and you want to consolidate that approach over the next 3 or so years.
Yeah, I think one of the interesting thing I find that sometimes patients in the clinic will come up and ask, can I look forward to stopping this drug, especially, as the discussion for TFR has been increasing. And because the other aspect of it that you've rightly mentioned, that the patient being able to do the test and then being able to work towards maintaining that response by being adherent to their medication being also very key. So that as we communicate to patients, they don't think that this is like other chronic diseases where you just say, okay, now you're well, which is the other challenge sometimes we find in the program, that when patients, because they are very sick, since most of them come with advanced disease, they're very sick when they start, and this medicine, improves their life. Right. That's clean. Their feeling goes away, and then they think they're okay. Then they stop their medication, and the problem begins there.
Yeah. And I wonder whether that's what happened with this patient, and that's why maybe I had that increase to 12 months. I imagine that getting a result of 1.3 might have made him concerned and get him back on taking his drug every day. And I think that how we talk to our patients is really so critical to motivate them to take their medication every day, so that one day they'll have a possibility of stopping. I think that's a really important message. And I think before we had that idea, that concept of treatment-free remission, I think drug adherence was a really difficult issue for all patients, really. So I think that's why it's so valuable to include it in the conversation. But I guess the challenge is, if a patient can't do PCR testing, it's hard to know how you talk about treatment-free remission, because there's not really a realistic option for them. And I guess I've never had to face that issue, and I guess you do have to face that issue. So how do you face that? Because if they ask you, can I stop one day, what do you say? No, because you can't afford to have a PCR test.
Yes. So that's a real question we face in clinic every 2 weeks. So one of the things is to highlight the importance of testing. So right now we really encourage patients, start saving money, just do the test at least once a year.
Yeah.
Because as you rightly said, getting that feedback of a test, you can actually see it in their faces when you tell them, look, this is what your PCR is right now. And that somehow motivates them to look for money for the test for the next year. And to be honest, for some patients who say, I don't have the money, then we just tell them, for you, you need to be on the drug. But then still emphasizing that in order to know how you're really doing, because we don't want to wait for a loss of hematological or a clinical response, we still encourage you to do the test at least once a year. So we try and pass that message in different ways. And even if they're not able to do it this year, we tell them, that's fine. Let's work towards next year so that at least they have something beyond the initial BCR-able.
Yeah. I mean, I think the most important test from my point of view, the most important test would be probably at 6 months. I mean, it's lovely to have it for 3 months, but even in a situation where you can do the tests very regularly, we would often sort of not necessarily change at 3 months if the result wasn't clear cut. So at 6 months, you know that if they are, certainly if they're more than 10%, that they really need to change therapy, and if at all possible. And that maximizes the value of the test. So if I was going to do one test in a patient, I'd probably do it at 6 months, and then if possible annually, I guess. And that's if possible.
Now, because I'm watching the clock, I might encourage you, Matilda, to move on to your second test, second case. But I'll also say that Professor Sue Branford and Professor Latif Salawa are also in the room, so to speak, both very experienced in TFR, and we welcome your comments or questions in relation to this session as well. Matilda?
Yes, thank you. So this next case is slightly longer, so it brings out some of the factors that we have discussed. So this patient has been in the program for 15 years now. She started in 2008 when she was 46. At the time, she presented with a typical, left upper quadrant swelling, symptomatic anemia, but she did also have heavy menstrual bleeding, no comorbidities. Her spleen was 8 centimeters below the costal margin, and you can see those were the counts that she had at presentation. So marked leukocytosis, her platelet count was elevated, but also noting that she has a microcytic anemia. At the time, what she was able to do was a FISH, and for the BCR-able testing. At the moment, we are doing that if the PCR is negative. Then the bone marrow showed she was in chronic phase, and she was initiated on imatinib. So she's been in the program for some time. So I've just done her summary in terms of year by year. She had initial dependent lower limb edema, but expected, because one of the side effects we see with imatinib earlier on is fluid retention. But also remember, this lady had heavy menstrual bleeding causing chronic anemia, and she had been talked to about reviewing this, referred to a gynecologist. However, she didn't follow that up. She was only able to do a BCR-able 2 years later, which actually showed she was in a deep molecular response. So at this time, because she was also, she had a few counts of her low HB, for some reason, her dose was reduced. I think at this point, probably what we would have done is dealt with the heavy menstrual bleeding, which is what was really driving the anemia rather than the drugs, because that's another common thing that we have in our setting, where we notice that patients get very sensitive to the TKIs. So many times we are having challenges of cytopenias in the context of using even just imatinib, and the patient is having a good molecular response. So eventually she did visit her gynecologist was found to have uterine fibroids, also had a pap smear that showed some dysplasia. So she did have a total abdominal hysterectomy, and it was clear that this really helped her in terms of her hemoglobin being much better. Her dose was up to 400 milligrams. And then, you know, she's been able to do the BCR-ABL erratically. And so this is what we usually have in clinic. So at the beginning, it was also more costly. It was more than the price I've indicated there is the current, the $81. So before it was double the price. So, and she was only able to do, she did one in 2015, but it was documented as an MMR, but I didn't get that report. And then she had her TKI stopped, which was also another interesting thing. But hematologically, she was doing well. Clinically, she was okay. But you can see we have just 2 readings. And also, if she had an MMR at 2015, probably it was a premature stop. But she did a BCR-ABL in 2017, and it was 0.017. But you can see she did lose her molecular response and went up to 1% in August. So she was reinitiated on the imatinib. And thereafter, she had another test the next year, but achieved, she responded. So again, mimicking what has been shown in the studies, that if you identify early, reinitiate your treatment, then the patients have a chance of responding. She didn't have any issues during the COVID era. So just to highlight in a few minutes about the TFR program, we had slots for 4 patients. This was supported through the GPAP Now Max Access Solutions program, where they needed a patient to have been on a TKI for 10 years and at least have 2 BCR-ABLs that were within a year, so 6 months, that were in deep molecular response. So if a patient didn't have that and maybe they did 1 BCR-ABL, the program facilitated in doing the next before they were recruited. So only 3 patients have been able to enroll in that program, and this is one of the patients. So of course, thereafter, because now she's joined the TFR program, the BCR-ABLs are supported and she's not paying out of pocket. So that's why you're seeing all the readings. And I only picked a few, but she did have the monthly BCR-ABLs for the first 6 months and then 3 months. And she's now doing them every 6 months. And you can see, just in summary, that she's actually maintained a deep molecular response to date. Her last visit was in May. And so a few nuances about this patient. So she's been a chronic phase CML patient, been in the program for 15 years. We don't know what happened for the first few years. Like, we can't really say she was in a deep molecular response the first few years and she never had. We can only assume. And then she had a stop in her medication, but not per the guidelines. And you can see quickly she lost her molecular response, therefore emphasizing the importance of being able to monitor. Otherwise, you put this patient at risk. And then there's the issue of duration of TKI. So for the program, they were keen that the patient had to be on TKI for 10 years. The Latin America group showed 5 years. And for patients who are on imatinib in the EuroSky trial, they showed that the longer duration of imatinib improved or increased their chance of being in TFR. And not losing that response. So maybe should we consider longer duration for our patients? But then understanding there's this blind period for many patients that will not have, BCR-ABLs to say what was happening in the past 2 years or past 3 years. And this patient had actually a second TFR attempt, and she's actually doing well so far, but with monitoring. So emphasizing blind stopping of the TKIs is dangerous, but when you monitor, it's actually important. Yeah. So over to you, Prof. Hughes.
Okay. Yeah, interesting case. So her imatinib was stopped the first time. Was that the physician decision or the patient's decision? Or it's not clear really? What
Yes.
happened?
Yes, it was the physician decision. So it was, let's just say it was an independent decision, but based on the previous BCR labels. But again, I think at that time we had like discussions amongst us saying, you know, we need to monitor has she met the guidelines. So I think this case goes out to point that if you stop blindly
Yes,
and you don't monitor, you put the patient at risk.
That's right. Although she actually only had a fairly slow rise because she wasn't alarming even after a year or so of being off drug. So she probably didn't have a rapid rise, which gives her a good chance of success when she tries again, which has been the case. She tried again under appropriate conditions, and it's been successful. So I'm interested. I remember talking about the GPAP program, and I think we did feel that 10 years was a good conservative place to start. We wanted to get some successes in the program so that people could get some confidence in treatment-free remission. So we thought the best place to start would be in those patients who had many years of imatinib. And I think she's a good example of that. And you say that you've only had 4 patients go onto the GPAP TFR program. Is that because they only have very few slots available, or is it just it's very, very hard to find eligible patients?
So the slots were only available for 4 patients, and we're only able to get 3. The other patients either didn't qualify because of not having a 1 year, period where they have a deep molecular response. So, they didn't meet one of those criteria. Because what the program did is if a patient did a BCR label, then they matched and did one in 6 months, so that then if they're in deep molecular response, then they would join the program. Yeah.
Okay. I think there's some questions on the in the chat, maybe that you or I could address. There's a question. Is the patient out of chronic phase in the 15-year period? I don't think the patient has ever been beyond chronic phase, as far as we know, have they? They seem to be, they were just responding to drug at a variable level, but never out of chronic phase.
Yes. And the patient has always been in chronic phase.
Right.
Yes.
Right.
Yes. And then for the sendouts were usually the fish. So initially, mostly what we would get were fish reports for the Philadelphia chromosome, because there's a question about were we sending out for quantitative PCR? And there's challenge in sending out for quantitative PCR. In fact, I interacted with one a few weeks ago, because you can get and that will be dealt with the lab team actually, in terms of a good sample and the sample degenerating, and you can get a false negative.
Yes.
So the patient who had a false negative, yeah.
Yeah, but I'm impressed you can get your turnaround. I guess that's the nature of Gene Expert. You can get a result virtually straight away, which is incredibly valuable when you're only getting very intermittent PCR testing. At least you can get the result quickly and act on that result. And someone's asked, Dr. Olawaju, how reliable are the qPCR results from outside?
Yeah, so what we've tended to do is we've identified a few labs, major labs, which give the reliable tests. So we try to send patients to those labs. Or where a patient has a result that comes, sometimes at initiation, you have a patient whose PCR label is like 0 point something. And, there's that issue of the sample adequacy, and we leave that to the lab group. So we send them to specific labs where we've had reliable reports. Yeah.
Right. And can I ask you, Matilda, how many patients do you know Because this TFR program from GPAP is not just in Kenya, it's more widely applicable, isn't it? Do we know how many patients
Yes.
joined that program altogether? Do we have any, has that ever been presented, or do you have any data on that?
No, I don't, but that's a good question. Maybe I'll forward that to the coordinator to forward it to the international team. Yeah.
How long has it been going for?
So now we've had patients for the past 3 years now.
Okay, so we should be getting some interesting data on that. That'd be really interesting.
Yeah.
So we would be good to ask the lab to include ABL1 copy number. Yeah, I think that's an important thing if you want to know the sensitivity of the assay.
Yes.
It's good to include the
Yeah.
control gene copy number.
Yeah, and for this particular patient I spoke about, in fact, what I was able to realize, because the ABL copy number was less than 10,000, and that's what made me say, this is an unreliable test.
Yeah.
We need to repeat, and sure enough, when we repeated, it was more than 55%.
Right. Okay. We'll probably
I don't see any other question.
Oh, Jerry has an abstract. Nicola, thank you. Jerry has an abstract with Ash on the Max TFR project. That's interesting. I didn't know that.
Good.
Right. I mean, it must have reasonable numbers if he's going to present it at Ash. That's good.
Latif, would you like to give some reflections from a different part of Africa?
And there's also a question even with regard to that.
Well, most of what Matilda just said also apply to us. If you look at what I wrote in my slides, let me say for now, we have 1,500 active patients. And again, the mean age for our own is about 38 years. Okay. So, well, for the TFR, currently we have only 2 patients on TFR. And those are the people that can actually afford the testing for now. Well, those are the things I can give. There are also the problem of testing. We also have that similar problem. Now, because of the distance of a patient, some of the patients to our clinic, some of them will want to do their test. And we found out that some of them are not accurate. So they have to ask the patient to do those tests when they get to our centers again. So those are the things I can give for now on what Shah just presented.
So the person with the virtual hand raised, Alcatel 1, please feel free.
Thank you. I am Martin. I am a PhD student in Cameroon. I am very interested about the diagnosis of CML patient. So I have a question about the presentation, please. Is there a minimal time where patient under ITK can think about TFR? I mean, maybe if a patient is under ITK since maybe 1 year, 2 years, or it only depends on the molecular response. Thank you.
Matilda, do you want to respond?
Yes. So that's a very good question. So most guidelines, like the EuroSki study and the STEAM study, the patients had at least be on a TKI for 3 years. There's some guidelines that say 2 years, and the patients having been in a deep molecular response for at least 1 year. The Latin America group, and that's why I referenced it in the article. If you go through it, it's a very good article, very, very well written and simple to understand. They recommended 5 years, but that's because many of the centers have the challenges that we have. And the reason being that the research has shown the longer exposure, this is true for imatinib because the subgroup analysis was on the imatinib, longer exposure to the TKI was associated with a higher chance of response and the patient being able to achieve that treatment-free remission. So the longer the duration, the better, per the guidelines. 3 years, on some 2 years. For Latin America, they've put 5 years, with 1 year being a deep molecular response. I don't know if you want to add anything, Prof.
Yeah, I mean, we talk about treatment-free remission being very safe, based on large numbers of patient studies now, and there are almost 3,000 patients where we have either registry or clinical trial data, and it is safe. I mean, the risks are very low, but nearly all those patients have had prolonged exposure to a TKI. I mean, our typical patient in Adelaide on imatinib has had 7 or 8 or more years of drugs, sometimes more than that, before they've stopped. So while there are trials now looking at stopping it, even 2 and 3 years, they're very much trials, and we certainly wouldn't recommend that in a situation where you're not going to do monthly PCR and not going to be able to follow the patients very closely. So that I think in the setting where you are very much limited in your PCR testing, I think you need to be very conservative about when you decide to stop. And unless there's a compelling need, such as obviously a pregnant lady, and also a woman who wants to have children and expresses a real urgency, I'd be very reluctant to stop any patient in less than 5 years. I mean, that may become different as we get more information about the use of the second generation drugs. But even now, the experience is really quite limited in stopping patients less than 5 years, and certainly less than 3 years. So I think that's probably a good rule to stick to for the moment. You need to be patient, because otherwise you can't rely on the safety data that we've generated over the last 15 years. That's all related to a specific context of long exposure to TKI therapy.
Matilda, would you like to have a last comment?
No, I agree completely with what Prof. Tim Hughes has mentioned. If you can't monitor, don't stop. That's what I would say.
Good rule.
A very strong message there to end the TFR topic, I'm afraid. How incredibly quickly 40 minutes passes. Thank you very much, Professor Tim Hughes and Dr. Matilda Ong'ondi, for your incredible insight and wisdom, and to all of the audience members for bringing their questions forward in the chat, and one brave person who does it by raising their hand. Please, everyone, these are interactive and inclusive discussions. Please get stuck in. You're so welcome to have your say. If you submitted a question in the chat that we didn't get to, I will try and get back to you with a response from Matilda or Tim ASAP.